Welcome back to the Deep Dive, your express lane to understanding the stuff that really matters. You know that feeling, right? When a doctor mentions some complex term or a news headline about health just leaves you scratching your head, wishing you had a shortcut to genuinely understanding what's going on with your body or maybe the health of someone you love. It's that desire to move past the information overload and really grasp the crucial insights. Well, today's Deep Dive is precisely that shortcut. We're taking a comprehensive stack of knowledge and think of it as like the ultimate health exam for your ears. And we're distilling it into the most vital nuggets of knowledge across some really impactful health areas:
Yeah.
cancer, blood disorders, and kidney health.
And by the end of our conversation today, you won't just know what these conditions are. Our mission really is to equip you with a clearer understanding of, well, prevention, the power of early detection, the intricate ways diseases actually develop, and, of course, how modern medicine steps in to try and restore health. We're moving beyond just the surface facts to explore the why and the how.
Exactly. Our source material for this deep dive is a pretty robust drawing from extensive research, clinical insights. Our goal is just to transform this wealth of information into actionable, memorable insights tailored just for you, our curious learner, so you can feel more informed, more empowered on your personal health journey. Okay, let's unpack this right away with something incredibly important. Recognizing cancer's early warning signs. You know, our bodies are constantly sending us signals. The trick is knowing which ones to really pay attention to. Some people just dismiss persistent issues as, getting older or maybe a sensitive gut, but our sources really reveal why paying close attention, why noticing these seemingly minor, persistent shifts can be a game changer for early cancer detection. It's all about recognizing your body's new normal. So, what are these crucial signals? Let's focus on a few key ones that really stand out. First, changes in bowel or bladder habits. We're not talking about a one-off upset stomach, right? We mean persistent changes that are unusual for you. Maybe it's stubborn constipation or diarrhea that just won't go away. Or maybe a noticeable change in how often or, how easily you're passing urine.
Yeah, and what's often overlooked here is the persistence, like you said. A temporary change might be nothing, could be anything. But if something lingers for weeks and weeks without a clear explanation, that's when it really warrants a conversation with your doctor.
Mhm.
It's about recognizing that your body's typical rhythm, its pattern, has been interrupted somehow.
Absolutely. Another critical sign is a sore that does not heal. This is particularly concerning if it's, say, on your skin or maybe inside your mouth. Our bodies are usually incredibly efficient at healing wounds, cuts, scrapes. So if you have a cut or maybe a lesion that just lingers or maybe seems to get worse instead of slowly scabbing over and disappearing, well, that's a call for investigation.
That's a vital point because, you see, a non-healing sore suggests there's an underlying issue disrupting that normal cellular repair process.
Mhm.
This can be a significant red flag for certain types of cancer, especially skin cancers or oral cancers. And with those, early intervention can make all the difference.
Then there's unusual bleeding or discharge. Now, this is anything that's beyond what's normal for your body. For instance, postmenopausal vaginal bleeding is never normal, or blood in your urine or stool when it wasn't there before, or really any unexplained discharge that just seems out of the ordinary. It's about knowing your personal baseline and noticing those deviations. And of course, a thickening or lump in the breast or elsewhere. This is where self-checks become incredibly important, right? Not just for breast, but really for any part of your body, where you might notice an unexplained lump or thickening. And don't forget, regular physical exams by a physician are just as vital. They can often detect things you might miss yourself.
That really highlights the synergy, doesn't it, between self-awareness and professional medical examination. While finding a lump doesn't automatically mean cancer, its presence, especially if it's new or changing, absolutely requires a thorough medical evaluation. For something like breast cancer, for example, early detection in this way significantly improves treatment outcomes.
Right. And finally, a nagging cough or hoarseness. When is a cough more than just a cold? Well, if you have a cough that lingers for weeks and weeks without explanation, or if your voice becomes persistently hoarse without a clear cause, like, say, yelling at a game, it's a signal that needs attention, especially for people with a history of smoking.
Exactly. And collectively, these signs, it's important to stress this, they aren't definitive diagnoses of cancer. They're more like urgent calls for investigation, your body's early warnings. Acting upon them leads to timely diagnosis and, usually, significantly better outcomes because of that early intervention. Ignoring them, hoping they'll go away, that's where the real risk lies.
So, okay, once we know what to look for, how can we actively reduce our risk? What does health promotion actually look like in the context of cancer prevention? It often comes down to making proactive choices in our daily lives, right? And a big part of that starts with what we eat, what we put on our plates. When it comes to dietary habits for cancer prevention, our sources offer some pretty clear guidelines. We want to be mindful of excessive intake of, say, animal fat and also nitrates. Nitrates are often found in highly processed meats, think lunch meats, sausage, bacon. Minimizing red meat consumption is also generally recommended. And for alcohol, the advice is usually to keep consumption moderate. Typically no more than 1 to 2 drinks per day.
hmm And on the other hand, there are some powerful dietary allies you really want to embrace. Fiber-rich foods like bran are great. And also cruciferous vegetables, things like broccoli, cauliflower, Brussels sprouts, cabbage, those are incredibly beneficial. These vegetables actually contain compounds that are thought to actively protect against cancer development. It's also vital to get enough foods high in antioxidants, like vitamin A found in carrots, leafy green vegetables, and vitamin C, which is abundant in fresh fruits, especially citrus. And the science behind this is actually quite clear. Fiber aids digestion, helps move potential carcinogens through your system more quickly. Antioxidants like vitamins A and C, well, they protect your cells from damage by free radicals. And that damage can contribute to DNA mutations and eventually cancer. Limiting those processed meats reduces exposure to pro-inflammatory compounds and potential carcinogens formed during processing. It's really about fueling your body's natural defenses.
Makes sense. And beyond diet, there are broader primary prevention methods. These are actions taken to prevent cancer from ever developing in the first place. A major one is simply avoiding carcinogens, which means identifying and actively staying away from common environmental and lifestyle carcinogens, obvious one, tobacco smoke, or, say, excessive UV radiation from the sun. We also have powerful tools like vaccination. It might sound surprising to some, but certain vaccines are a real triumph of modern medicine in cancer prevention. They specifically target virally induced cancers. This actually leads us perfectly into something we'll discuss a bit later, but it's worth highlighting now. How vaccines aren't just for infectious diseases like measles or flu, they can also be a shield against certain types of cancer. Okay, here's where it gets really interesting for me. Beyond prevention, how do we catch things before they become a bigger problem? What tests should you, the listener, be aware of? This is all about secondary prevention, right? Catching disease early, often before symptoms even appear, when treatment is generally most effective.
Exactly. These screening tests are crucial because they can detect precancerous changes, or cancer, at its earliest, most treatable stages. Knowing these recommendations and actually adhering to them can truly be life-saving. Now, there are many screenings, of course, but let's focus on a few key ones that most adults should probably be aware of.
Okay, like for cervical cancer, women typically get pap smears for that, right? Those detect abnormal cells. Guidelines generally suggest women aged 21 to 65 get a pap smear every 3 years, or I think every 5 years if it's combined with an HPV co-test.
That's right. And for breast cancer, mammograms are really the cornerstone. Women generally begin regular mammograms around age 40 to 45, continuing every 1 to 2 years. Earlier screening might be considered if you have a higher risk, like a strong family history of the disease.
Colorectal cancer screening is also vital. For adults aged 45 to 75, a colonoscopy is usually considered the gold standard, typically every 10 years, I believe, or maybe more frequently if polyps are found or there's a family history. There are also less invasive options, like annual stool-based tests. The key thing is just consistent screening with some method.
And for lung cancer, screening is specifically targeted. Low-dose CT scans are recommended annually, but only for adults aged 50 to 80 who have a significant smoking history, we're talking 20 or more pack years, and who currently smoke or have quit within the last 15 years. This specific group benefits most from early detection.
It's so important to remember that these are general guidelines, though. Who should get what test, and how often those are crucial details that you should always discuss with your own healthcare team, because your personal risk factors, your history, all that will influence the best screening plan for you.
Now, what's truly fascinating, and maybe a bit scary, is how a single abnormal cell can escalate into a widespread threat. Let's try to trace cancer's incredible journey of spread, a process we call metastasis. It all begins with this loss of cellular regulation. Rogue cells basically hijack the body's normal growth controls. And we distinguish between a primary tumor, that's where the cancer first started, the origin, and a secondary or metastatic tumor, which forms after those cancer cells have traveled, usually via the lymph system or the bloodstream, and set up shop somewhere else.
So it's like a journey from a localized problem to a systemic one. Can you walk us through the actual steps of how that happens? It sounds incredibly complex.
It is, in a sort of sinister way. The first step is malignant transformation. This is when normal cells essentially lose control. Their DNA gets damaged, leading to uncontrolled division, uncontrolled growth. They start ignoring the body's stop-growing signals, and they resist programmed cell death apoptosis. Basically, they become rogue cells, stop doing their original job, and become genetically unstable. Next up, we have tumor vascularization. Now, a small cluster of cancer cells, a tiny tumor, it can't grow beyond maybe 1 or 2 millimeters without its own dedicated blood supply. It needs nutrients, oxygen. So these clever cancer cells secrete something called tumor angiogenesis factor, or TAF. This TAF stimulates nearby blood vessels to grow new capillaries directly into the tumor. This is a critical step. It provides the oxygen and nutrients for rapid growth. And maybe even more importantly, it creates the highways, the blood vessels that cancer cells will later use to enter the general circulation and spread.
Wow, so the tumor essentially builds its own infrastructure to sustain itself and eventually spread. It's like it's setting up its own supply lines and escape routes. Okay, so once it has that blood supply, what's the next stage?
That leads us to invasion. At this point, cancer cells develop the ability to physically penetrate the surrounding healthy tissues. They can even break through the protective membranes around them. They do this by secreting specialized enzymes like collagenase that effectively break down the glue, the extracellular matrix, that holds our tissues together. This allows them to physically move into nearby structures, that's local invasion, and eventually enables them to enter lymphatic vessels or blood vessels. And from there, the full journey to metastasis unfolds. Once they get inside the circulation, cancer cells enter the bloodstream. We call that intravasation. Then they travel through the circulatory system. Often they cleverly shield themselves by clumping with platelets to evade detection by the immune system, almost like wearing a disguise. Eventually, they leave the circulation at a new site, that's extravasation, and invade that new tissue environment. And finally, these cells begin to grow in that new site, forming a secondary or metastatic tumor.
So what does understanding all this mean for treatment? Knowing these intricate steps seems incredibly important for how doctors actually fight cancer.
Oh, absolutely. These steps explain why targeted therapies that block angiogenesis, remember, the blood vessel growth, like the drug bevacizumab or avastinel, why those can be so effective. By cutting off the tumor's blood supply, you're essentially cutting off its lifeline. You slow its ability to grow and spread. It also helps us understand why cancers often metastasize to organs with really high blood flow places like the lungs, the liver, bone, the brain. These are prime locations where circulating cancer cells are likely to settle and find a hospitable environment to grow. For instance, breast cancer commonly spreads to bone and lungs. Colorectal cancer often finds its way to the liver. This predictable pattern helps guide surveillance and, of course, treatment strategies.
This raises an important question. We often think of viruses making us sick with, colds or the flu. But you mentioned earlier that some can actually lead to cancer. That's a connection many might not immediately make, and it feels like a crucial insight.
That's right. These are what we call oncoviruses, viruses that have the potential to cause cancer. They do this by subtly altering the DNA, or maybe the gene expression in the cells they infect, leading to uncontrolled cell growth. Now, it's really crucial to understand that not everyone infected with an oncovirus will develop cancer. The risk depends on a complex interplay of factors, things like an individual's immune status, their genetics, other environmental exposures.
So how do these tiny invaders actually manage to turn a healthy cell cancerous? What's their attack plan in simple terms?
Well, oncoviruses have several clever ways to manipulate our cells. One key mechanism is by inserting their own genetic material directly into the host cell's DNA. Integration, we call it. Once integrated, their genes can interfere with our cell's normal functions, essentially giving it bad instructions, pushing it towards cancer. Another way is by activating specific genes that promote cell growth oncogenes, or by inactivating genes that normally keep cell growth in check tumor suppressor genes. Kind of like hitting the gas and disabling the brakes at the same time. Some oncoviruses also cause chronic inflammation, and we know that persistent inflammation can promote mutations and create an environment where cancer can thrive.
That's quite a sophisticated set of strategies. Can you give us a few specific examples of these human oncoviruses and the cancers they're linked to, especially those where prevention is possible?
Certainly. One of the most well-known is the human papillomavirus, or HPV. HPV is responsible for a significant number of cervical cancers, but also anal, throat, and other cancers too. It's primarily transmitted through sexual contact. The great news here is that we have a highly effective HPV vaccine, which can prevent the infections that lead to these cancers. And regular pap smears are also crucial for early detection of cervical changes caused by HPV. Then there are the hepatitis B virus, HPV, and hepatitis C virus, HCV. Both are major causes of liver cancer or hepatocellular carcinoma. HPV can be transmitted through blood, sexual contact, even from mother to child at birth. HPV is mainly transmitted through blood contact, like sharing needles. For HPV, there's also a very effective vaccine. And for both HPV and HCV, there are antiviral treatments that can manage the chronic infection and significantly reduce the risk of progressing to liver cancer. Regular liver monitoring for those with chronic hepatitis is also vital. These vaccines, particularly the HPV and HPV vaccines, they really represent a true triumph of modern medicine and cancer prevention. They actively prevent the initial infections and cellular changes that could otherwise lead down the path to life-threatening diseases. Understanding this viral connection to cancer empowers us all to take proactive steps through vaccination, safe practices, and appropriate screening.
So, okay, once a cancer is identified, how do doctors even begin to describe its severity? How do they plan the best course of action? It can't just be you have cancer, right? There must be a more detailed system.
Oh, absolutely. That's where the TNM system comes in. It's essentially the universal language doctors use globally for cancer staging. And it's absolutely critical because it guides treatment decisions and helps predict a patient's prognosis, their likely outcome. TNM stands for tumor, nodes, and metastasis.
Okay, let's break that down, but maybe in a way that helps us grasp the core concepts without getting lost in overly clinical details. What does each letter signify?
Right, think of it like this. The T describes the tumor itself, primarily its size and how much it has grown into the surrounding tissues. So a T1 might be a very small, localized tumor, while a T4 indicates a much larger tumor that's invaded nearby structures quite extensively. The N describes whether the cancer has spread to nearby nodes, specifically the regional lymph nodes. Those are the first drainage points. N0 means no lymph node involvement found. N1, N2, or N3 would mean spread to an increasing number or size of nearby lymph nodes. And finally, M stands for metastasis. This tells us if the cancer has spread to distant sites in the body, beyond those regional lymph nodes. M0 means no distant spread has been detected, and M1 means distant metastasis is present.
Can you give us a simplified example of how this comes together, just to make it concrete?
Absolutely. Let's imagine a diagnosis like T2N1M0. In simple terms, this would translate to a moderately sized tumor, P2, with spread detected in a few nearby lymph nodes, N1, but crucially, no evidence of distant spread to other organs, M0. This particular combination, T2N1M0, would typically correspond to an overall stage 2 or stage 3 cancer, depending on the specific type of cancer we're talking about. These TNM values are then grouped into an overall stage number, usually ranging from stage 0, which is carcinoma in situ, very early, non-invasive cancer, up to stage 4, which means the cancer has spread distantly, M1 is present. This standardized system allows doctors to communicate precisely about a patient's cancer, ensuring personalized treatment plans are developed based on the tumor's specific behavior and how far it has spread.
When it comes to treatment, radiation often comes up, and it can sound pretty intimidating. What exactly is radiation therapy trying to achieve, and how does it work to fight cancer?
That's a good question. The core purpose of radiation therapy is to deliver a very high dose of radiation directly to the cancerous area, while meticulously limiting the exposure to the surrounding healthy tissue as much as possible. The goal is basically to damage the DNA of the cancer cells. This prevents them from growing and dividing, and ultimately leads to their destruction.
And there isn't just one type of radiation, right? I gather there are different ways it can be delivered.
That's correct. There are a few main approaches. One, external beam radiation. This is probably what most people picture. Radiation is delivered from a machine outside the body, precisely aimed at the tumor site using sophisticated imaging. Two, internal radiation, or brachytherapy. This involves placing a radioactive source directly inside the body, either right in the tumor or very close to it. This source could be temporary, like small implants or catheters that are removed later, or it can be permanent, like tiny radioactive seed implants that remain in the body but lose their radioactivity over time. Brachytherapy is often used for cancers like prostate, cervix, or breast cancer.
Okay. Since radiation targets living cells, both cancerous and, to some extent, healthy ones nearby, there are bound to be side effects. What kind of care is involved for patients going through this? And what are the crucial safety points, especially when dealing with radioactive materials and brachytherapy?
Absolutely. Patient education and meticulous nursing care are vital for managing side effects and ensuring safety. For skin care in the treated area with external beam radiation, patients are typically advised to gently wash with mild soap and lukewarm water. Pat the skin dry, no rubbing, and avoid harsh lotions, perfumes, or deodorants unless specifically prescribed by the radiation oncology team. Protecting the skin from sun exposure is also really important. Fatigue is a very common side effect across the board with radiation. So, encouraging rest periods and helping patients prioritize their activities is key. Other common side effects can include skin changes like redness, dryness, or peeling, and maybe some hair loss, but only in the specific area being treated. A key teaching point is that these side effects are usually localized to the treatment area and typically start to appear about 1 to 2 weeks after treatment begins. Patients need to know to report severe pain, fever, any unusual bleeding, or signs of skin breakdown immediately. Now, regarding safety, this is critical. For external radiation, the patient is not radioactive after the treatment session. No special precautions are needed for family or friends. However, with internal radiation or brachytherapy, the patient is radioactive while that source is in place. This means specific precautions are necessary. Visitor time is usually limited, maybe 10 to 30 minutes per visit, and they need to maintain a safe distance, typically around 6 feet. Healthcare staff will use shielding, like a lead apron, if close contact is absolutely necessary. And crucially, no pregnant visitors or pregnant staff members are allowed near the patient while the internal source is active.
Chemotherapy is another big one, and it's well known for being a pretty intense treatment, often with significant side effects. What are its major effects on the body, and how do medical teams manage those really intense complications?
You're right, chemotherapy is a systemic treatment. That means it travels throughout the entire body to target rapidly dividing cancer cells. But because it's not perfectly selective, it also affects other healthy cells in the body that divide rapidly, like hair follicles, cells lining the mouth and gut, and bone marrow cells. This is what leads to many of its well-known complications. Healthcare teams are highly skilled at anticipating these side effects and proactively managing them.
So let's go into some of the most significant complications and how they're handled. Understanding these can really help a patient prepare, I think.
Definitely. One of the most critical is myelosuppression. That just means a decrease in the production of blood cells by the bone marrow, specifically white blood cells, red blood cells, and platelets. This vastly increases the patient's risk of infection due to low white cells, anemia and fatigue due to low red cells, and bleeding due to low platelets. Interventions include strict hand hygiene, avoiding sick contacts in crowds, careful monitoring of blood counts, sometimes using growth factors to boost cell production and transfusions if needed. Nausea and vomiting are also very common. The key intervention here is often giving antiemetics like ondansetron, which is Zofran, before the chemotherapy treatment even begins. Encouraging small, frequent, bland meals can also help. Painful mouth sores or mucositis dermatitis are managed with meticulous oral hygiene using a soft toothbrush, gentle saline rinses, and avoiding acidic or spicy foods that can irritate the mouth. Topical anesthetics can provide relief too. Some chemotherapy drugs can cause peripheral neuropathy, which is that unpleasant numbness or tingling, often in the hands and feet. Patients need to be assessed for sensation changes, taught fall precautions, and advised to avoid extreme temperatures. And of course, alopecia, or hair loss, is a very common and often emotionally distressing side effect. Preparing patients beforehand, offering resources like wigs or scarves, and providing emotional support is vital. It's also important to reassure them that hair usually begins to regrow a few weeks after treatment ends.
Given how potent these chemotherapy medications are, there must be strict rules for how healthcare providers handle them, and maybe even precautions for families at home.
Absolutely. Safety is paramount. For healthcare providers, it's essential to wear specific personal protective equipment, or PPE. This includes chemotherapy-approved gloves, gowns, and eye face protection. Preparation often happens in a special ventilated cabinet. For patients and families at home, education is key. They need to understand how to handle body fluids, urine, stool, vomit safely, usually wearing gloves for about 48 hours after treatment, as the drugs or their byproducts can be excreted. Flushing the toilet twice is often recommended. And even oral chemotherapy pills are hazardous drugs. They generally shouldn't be crushed or split unless specifically approved, as this can release dangerous particles into the air. It's really a testament to modern oncology care that while chemotherapy is intense, we have incredibly sophisticated methods to manage its side effects, allowing patients to complete their vital treatment with as much comfort and safety as possible.
Okay, sometimes, despite the best possible care, cancer itself or its treatments can lead to sudden, really life-threatening situations. These aren't just complications, they're genuine medical crises. What are these oncologic emergencies, and why is it so critical to recognize them quickly?
You're right. These truly are medical emergencies. They require immediate recognition and rapid intervention to prevent severe harm or even death. Early detection and a fast response from both healthcare providers and, importantly, alert caregivers or family members can make all the difference in patient outcomes. Let's focus on a few of the most critical ones. First, sepsis. We hear this term a lot. It's a life-threatening, extreme response by the body to an infection, and it leads to organ damage. In cancer patients, especially those whose immune systems are weakened by treatment, sepsis is a huge risk. You typically see a cluster of warning signs, maybe a high fever or chills, a very rapid heart rate, fast breathing or shortness of breath, a sudden drop in blood pressure, confusion, maybe decreased urine output. If sepsis is suspected, it's a race against time. Treatment involves rapid 5E fluids, powerful broad-spectrum 5E antibiotics, started ASD, oxygen, and sometimes medications to support blood pressure.
So it's not just a bad infection, it's the body's overreaction to the infection that's so dangerous.
Got it. What's another urgent situation to be aware of? Another critical one is spinal cord compression. This happens when a tumor, often one that is spread to the bone in the spine, presses directly on the spinal cord. This pressure can cut off blood flow and damage the delicate nerves within the cord. The main problem here is the risk of permanent paralysis if it's not treated very quickly. Key warning signs include new or worsening back pain, especially pain that gets worse when lying down. Also numbness, tingling, or weakness, usually in the legs or arms. And in more advanced cases, a loss of bladder or bowel control. Treatment needs to be immediate. High-dose corticosteroids like dexamethasone to reduce swelling, followed urgently by imaging like an MRI, and then usually radiation therapy or sometimes surgery to relieve the pressure on the cord. And finally, let's touch on tumor lysis syndrome, or TLS. This is an emergency where, often after the start of chemotherapy for very fast-growing cancers, like certain leukemias or lymphomas, a large number of tumor cells burst open rapidly. When they burst, they spill their internal contents into the bloodstream all at once. The main problems this causes are dangerously high potassium levels, hypercalcemia, which can cause life-threatening heart rhythm problems, high phosphate levels, which combined with calcium, leading to low calcium, hypocalcemia, and muscle cramps or seizures, and high levels of uric acid, which can crystallize in the kidneys and cause severe kidney damage or failure.
And what would a patient or caregiver actually observe if TLS is starting? What are the signs?
The warning signs can include things like nausea, vomiting, diarrhea, muscle cramps or twitching, muscle weakness, a fast or irregular heartbeat, confusion, possibly seizures, and often low urine output because the kidneys are struggling. Prevention is really crucial for TLS in high-risk patients. This involves aggressive IV hydration before starting chemotherapy and medications like allopurinol or rasburicase to prevent uric acid buildup or break it down. If TLS does occur, treatment involves continuing aggressive IV fluids, medication to correct the electrolyte imbalances like lowering potassium, managing phosphate, sometimes giving calcium, and often rasburicase for the high uric acid. Sometimes dialysis is needed if the kidneys fail.
That truly emphasizes the critical role of vigilance for both patients and their caregivers. Knowing these signs, sepsis, spinal cord compression, TLS, and understanding their urgency can genuinely be a matter of life or death, pushing you to seek immediate medical attention without delay. Okay, if we can connect this to the bigger picture, our blood, it's our body's incredible transportation system, right? Delivering oxygen, nutrients, fighting off invaders. What happens when that system goes awry? It can lead to a whole range of complex conditions we call hematologic disorders.
That's exactly right. These disorders affect the blood itself or the blood-forming organs like the bone marrow, and they can have profound systemic impacts because, as you said, blood touches every single part of our body.
Let's start with a well-known genetic condition, sickle cell disease or SCD. What's actually happening inside the body for someone with this, and what are the critical things to look for, especially during a crisis?
In sickle cell disease, there's an abnormality in hemoglobin, the protein in red blood cells that carries oxygen. This abnormal hemoglobin, HbS, causes the red blood cells, which are normally flexible and disc-shaped, to become stiff and take on a crescent or sickle shape under certain stress conditions, things like low oxygen levels, dehydration, infection, even cold temperatures. These sickled cells aren't flexible. They get stuck in small blood vessels, blocking blood flow. This leads to poor perfusion, a lack of oxygen to tissues, hypoxia, tissue damage, ischemia, and really intense pain. This painful episode is known as a sickle cell crisis or vaso-occlusive crisis. During a crisis, pain is by far the most common and often debilitating symptom, but patients might also experience severe fatigue, pallor, looking pale, jaundice, yellowing of the skinnies, shortness of breath, and a fast heart rate. The immediate management during a crisis focuses on three key pillars: oxygen therapy, always humidified importantly, to improve tissue oxygenation, aggressive pain management, often requiring strong opioid medications given on a schedule or via PCA pump, and vigorous hydration, usually with IV fluids, to help reduce the concentration of sickled cells and improve blood flow. For chronic care, staying well hydrated, maybe 3 to 4 liters a day, avoiding known triggers, getting vaccinations, and sometimes taking a medication called hydroxyurea, which helps reduce the frequency of crises, are all crucial.
Moving on to another significant blood disorder, leukemia. This is often associated with the bone marrow, correct? It's a type of cancer.
Yes, exactly. Leukemia is a cancer where the bone marrow goes into overdrive producing too many immature or abnormal white blood cells. These abnormal cells, sometimes called blasts, don't function properly, and they crowd out the normal blood-forming cells in the marrow. This leads to a shortage of healthy red blood cells, causing anemia, healthy white blood cells leading to infection risk, even if the total WBC count is high, and platelets causing bleeding risk. We call this combination pancytopenia. So even though the white blood cell count might be very high, the patient actually has functional leukopenia, meaning they're highly susceptible to infection because those white cells aren't working right. Key signs to look for include persistent fatigue from anemia, unexplained fever from infection or the leukemia itself, easy bruising or pinpoint red spots called petechia from low platelets, frequent infections, and sometimes bone pain or enlarged liver, spleen, or lymph nodes. Management primarily involves chemotherapy to try and eliminate these abnormal cells. Preventing complications during treatment is paramount. Meticulous hand washing and avoiding sick contacts to prevent infection. And taking bleeding precautions like using a soft toothbrush, avoiding contact sports, and monitoring for any signs of bleeding.
And what about anemia? That's a very common issue where the blood just lacks enough healthy red blood cells. What are the main causes we should know, and how is it generally managed?
Anemia is common and has various causes, but two very frequent ones are iron deficiency, often resulting from chronic blood loss like heavy periods or GI bleeding, or simply poor dietary intake of iron and vitamin B12 deficiency. B12 deficiency can be due to poor intake, especially in strict vegans, or more commonly, the body's inability to absorb it from the gut, a condition called pernicious anemia. The general symptoms of almost any type of anemia include pallor, pale skin, profound fatigue, a rapid heart rate, tachycardia as the heart tries to compensate, and shortness of breath, especially with exertion. Management always involves addressing the underlying cause if possible. For iron deficiency, that means encouraging iron-rich foods, red meat, poultry, fish, leafy greens, beans, often alongside oral iron supplements, which are best absorbed when taken with vitamin C. For B12 deficiency, due to poor absorption, pernicious anemia, lifelong B12 injections are usually necessary because oral supplements won't be absorbed.
Okay. Finally, let's briefly cover transfusion therapy. While often life-saving, I understand reactions can occur, and it's vital for patients and caregivers to know what to do if that happens.
That's a crucial point. Blood transfusions are vital, but yes, patients can experience various types of reactions. These can range from relatively mild, like a fever and chills, febrile non-hemolytic reaction, or itching and hives, or allergic reaction, to much more serious ones. Serious reactions could include acute hemolytic reactions, where the transfused red cells are destroyed, anaphylaxis, severe allergic reaction with wheezing and shock, or circulatory overload, too much fluid too fast. The most critical first action, if any type of transfusion reaction is suspected, is to stop the transfusion immediately. Don't just slow it down, stop it. Then, you keep the IV line open with normal saline using new tubing, notify the physician in the blood bank right away, monitor the patient's vital signs and urine output closely, send the blood bag and tubing back to the lab for investigation, and treat the patient's symptoms as they arise. Rapid recognition and response are absolutely key to patient safety during transfusions.
Okay, from the lifeline of blood, let's shift gears to our body's incredible filtration and waste removal system, the kidneys and the urinary tract. What are the common issues we need to be aware of here, especially since they can range from, minor annoyances to really severe chronic conditions?
This system is absolutely vital for maintaining overall health, homeostasis. The kidneys don't just filter waste products from the blood to make urine. They also play critical roles in regulating blood pressure, balancing electrolytes, producing hormones that stimulate red blood cell production, and activating vitamin D. So disruptions here can indeed have widespread effects.
Let's start with something that's far more common than many people realize and can significantly impact quality of life. Urinary incontinence. What are the most common types and how are they generally managed?
You're right, it's very common, especially as people age, but it's not a normal part of aging. There are several types, but let's focus on the two most common. One, stress incontinence. This is leakage of urine, usually small amounts that happens during activities that increase pressure inside the abdomen. Think coughing, sneezing, laughing, lifting something heavy, or exercising. It's also due to weakened pelvic floor muscles, which can happen after childbirth in women, or due to prostate surgery in men, or just with aging or obesity. Management typically starts conservatively with Kegel exercises to strengthen those pelvic floor muscles, and sometimes lifestyle changes like weight loss, if appropriate. 2. Urge incontinence. This is often called overactive bladder. It involves a sudden, intense, overwhelming urge to urinate, which is immediately followed by an involuntary loss of urine, sometimes a large amount. Feels like you can't make it to the bathroom in time. It can be caused by neurological disorders, bladder irritation like from a UTI or bladder stones, or sometimes the cause isn't clear. Management often involves bladder training, trying to gradually increase the time between timed voiding schedules, and sometimes medications called anticholinergics, like oxybutynin, that help relax the bladder muscle and reduce those strong urges.
That covers a wide spectrum of issues there. Now, let's move to a very common infection. Cystitis, which is basically a bladder infection or a lower urinary tract infection, UTI.
Yes, cystitis is typically caused by bacteria ascending up the urethra into the bladder. The most common culprit by far is E. coli, which normally lives in the gut. A particularly important type, especially in healthcare settings, is a catheter-associated UTI, or CIUTI. This is actually one of the most common healthcare-associated infections. Patients with cystitis usually experience symptoms like urinary frequency, feeling like you have to go all the time, urgency, so I need to go now, dysuria, pain or burning during urination, and sometimes suprapubic pain or pressure, discomfort just above the pubic bone. It's worth noting that in elderly individuals, confusion or sudden change in mental status can sometimes be the only sign of a UTI. Diagnosis typically involves a urinalysis, looking for white blood cells, bacteria, nitrites, and sometimes a urine culture to identify the specific bacteria and guide antibiotic choice. Management includes completing the full course of prescribed antibiotics. This is crucial. Drinking plenty of fluids to help flush out bacteria, maybe using a medication like phenazopyridine for temporary pain relief, it turns urine orange, and practicing good perineal hygiene, wiping front to back for women. For COUA prevention in hospitals or care facilities, the key principles are: insert urinary catheters only when absolutely necessary, use sterile technique for insertion, maintain a closed drainage system, don't disconnect the tubing, keep the drainage bag below the level of the bladder, perform regular catheter care, and remove the catheter as soon as it's no longer needed.
And what about urolithiasis, commonly known as kidney stones? These are notoriously painful, aren't they?
Oh, indeed. Kidney stones, or renal calculi, can cause some of the most severe pain imaginable. They form when minerals and salts in the urine crystallize and clump together. Causes can include chronic dehydration, diets high in sodium or certain substances like oxalate or purines, certain medical conditions like gout, obesity, and sometimes just a family history. The primary symptom is renal colic. This is an excruciatingly severe, sharp, wave-like pain that usually starts in the flank, the side between the ribs and hip, and often radiates down towards the groin or genitals. Patients may also have visible blood in the urine, hematuria, nausea, vomiting, and be sweating profusely. If a stone causes a blockage, urine output might decrease significantly. Management focuses first and foremost on aggressive pain control, often requiring strong opioid analgesics or potent NSAIDs. Medications like tamsulosin may be given to help relax the ureter, making it easier for the stone to pass. Vigorous hydration, encouraging the patient to drink at least 3 liters of fluid per day, unless contraindicated, is crucial to help flush the stone out. Patients are almost always asked to strain their urine through a special filter to try and catch the stone when it passes. Analyzing the stone's composition is really important because it helps determine dietary changes or medications needed to prevent future stones.
Okay, now let's really dive into kidney conditions, moving from those acute issues like infections and stones to chronic disease. You hear terms like acute kidney injury and chronic kidney disease. They sound similar, but there's a big difference, right?
You're absolutely right. They are distinct conditions, although sometimes one can lead to the other. It's important to understand the difference. Acute kidney injury, AKI, is characterized by a sudden, rapid decline in kidney function. This happens over hours or days and is often reversible if the underlying cause is treated quickly. In contrast, chronic kidney disease, CKD, is a progressive, irreversible loss of kidney function that develops gradually over months or years.
Let's focus on AKI first. What are the common causes for such a sudden decline in kidney function, and how would someone know if it's happening? What are the signs?
AKI can originate from 3 main categories of causes. Pre-renal causes. These involve decreased blood flow to the kidneys. Think of situations like severe dehydration, shock, low blood pressure, significant blood loss, or severe heart failure. In these cases, the kidney structures themselves might be initially fine, but they're just not getting enough blood supply to function properly. Intrinsic or intrarenal causes. This means there's direct damage to the kidney tissue itself. This could be due to inflammation, like glomerulonephritis, exposure to toxins or certain medications, like some antibiotics, NSAIDs, or 5E contrast dye, infections within the kidney, or autoimmune diseases attacking the kidney, postural causes. These involve an obstruction in the urinary tract after the kidneys, preventing urine from draining out. This backup of urine puts pressure on the kidneys and damages them. Common causes include large kidney stones blocking the ureter, tumors compressing the ureter, or an enlarged prostate BPH blocking the bladder outlet in men. The most prominent sign of AKI is often oliguria, which means significantly reduced urine output, typically defined as less than 0.5 milliliter per kilogram of body weight per hour. Sometimes patients might even have anuria, no urine output. Other signs can include swelling or fluid overload due to the kidneys not removing excess fluid, fatigue, confusion, nausea, and potentially dangerous electrolyte imbalances, especially high potassium, hypercalcemia, which can cause heart rhythm problems. Management focuses critically on treating the underlying cause, restoring blood flow in prerenal cases, removing the obstruction in postrenal cases, or stopping the offending drug or treating the disease in intrinsic cases. Supportive care includes careful fluid management, sometimes restricting fluids, sometimes giving fluids, monitoring electrolytes closely, avoiding further kidney insults like nephrotoxic drugs or hypotension, and providing adequate nutrition.
Now, let's turn to chronic kidney disease, CKD. What usually causes this much slower, long-term decline in kidney function, and what are its broader impacts on the body?
The two leading causes of CKD in most developed countries are, by far, diabetes mellitus, both type 1 and type 2, and hypertension, high blood pressure. These conditions over many years slowly damage the delicate filtering units, glomeruli, and blood vessels within the kidneys. Other causes include chronic glomerulonephritis, long-term inflammation of the glomeruli, polycystic kidney disease, an inherited condition, and sometimes prolonged or recurrent episodes of AKI that don't fully recover. As CKD progresses and kidney function declines, it affects almost every single body system. You see problems with fluid and electrolyte balance, often starting with inability to concentrate urine, leading to needing to urinate at night, nocturia, then progressing to fluid retention, high potassium, high phosphate, low calcium. The kidneys also fail to excrete acid properly, leading to metabolic acidosis. Blood pressure regulation is impaired, worsening hypertension and contributing to heart failure. Anemia develops because the kidneys stop producing enough erythropoietin, the hormone that stimulates red blood cell production. Waste products like urea build up in the blood, causing symptoms like fatigue, loss of appetite, nausea, severe itching, pruritus, and in very advanced stages, a frosty deposit on the skin called uremic frost, along with confusion or lethargy. Doctors stage CKD based on the glomerular filtration rate, or GFR, which is an estimate of how well the kidneys are filtering blood, measured in ml/min. Stage 1 CKD means kidney damage is present, but GFR is still normal or high, 90. Stage 2 is mild decrease, GFR 60-89. Stage 3 is moderate decrease, GFR 30-59. Stage 4 is severe decrease, GFR 15-29. Stage 5 CKD is defined as a GFR less than 15 millimillimin, which is considered kidney failure or end-stage kidney disease, ESKD. At this point, kidney function is so poor that renal replacement therapy, dialysis, or transplantation is usually required to sustain life. When patients reach advanced CKD or ESKD, they often develop a clinical syndrome called uremia. This is the constellation of symptoms caused by the buildup of all those nitrogenous waste products in the blood. Symptoms include severe fatigue, anorexia, nausea, vomiting, metallic taste in the mouth, itching, confusion, and sometimes even seizures or coma if untreated. When uremia becomes severe, it's a clear indication to initiate dialysis.
You mentioned contrast dye earlier with AKI. I know that's a concern for people with CKD too, right? If they need a CT scan or heart cath that uses contrast.
Yes, that's a very important point. IV contrast dye used for imaging studies can be nephrotoxic, meaning it can damage the kidneys, especially in people who already have underlying CKD. This is called contrast-induced nephropathy or contrast-induced AKI. Prevention is key. Before any procedure involving 5A contrast, it's crucial to assess the patient's baseline kidney function, checking BUN, creatinine, and calculating GFR. If kidney function is significantly impaired, the risks and benefits of using contrast must be carefully weighed. If contrast is deemed necessary, preventive measures include aggressive hydration with 5E fluids before and after the procedure, using the lowest possible dose of a low osmolar contrast agent, and holding potentially nephrotoxic medications like NSAIDs or metformin around the time of the procedure.
Okay, so when kidney function declines significantly to that end-stage level, modern medicine offers incredible lifelines. What are the main ways we can replace kidney function when the kidneys essentially fail?
When a patient reaches end-stage kidney disease, ESKD, and their own kidneys can no longer support life, there are essentially three primary options for kidney replacement therapy: peritoneal dialysis, hemodialysis, and kidney transplantation.
Let's start with peritoneal dialysis, PD. How does that work, and who is it typically a good option for?
PD is a form of dialysis that uses the patient's own peritoneum, the natural lining of the abdominal cavity, as the filter. It's often chosen by patients who are relatively stable, have difficulty with vascular access needed for hemodialysis, or strongly prefer to manage their therapy at home and maintain more independence. The process involves surgically placing a soft catheter into the patient's abdomen. Then, a special sterile fluid, called dialysate, is infused through the catheter into the peritoneal cavity. This fluid then dwells inside the abdomen for a prescribed period, usually several hours. During this dwell time, waste products and excess fluid from the blood diffuse across the peritoneal membrane into the dialysate. Finally, the fluid, now containing the waste products, is drained out of the abdomen through the same catheter and discarded. This cycle of fill, dwell, and drain is repeated several times a day, or often overnight using an automated cycler machine. Patient education for PD is absolutely critical, focusing heavily on maintaining strict sterile technique during the exchanges to prevent infection, particularly peritonitis and infection of the peritoneum. Signs of peritonitis include cloudy effluent, the drained fluid, abdominal pain, fever, nausea. Patients must know to report these immediately. Also, they should never warm the dialysate bags in a microwave, as this can cause uneven heating and burn the peritoneum.
And the other main type of dialysis, the more widely known hemodialysis, HD, which is typically done at a dialysis center.
Right. Hemodialysis involves filtering the patient's blood outside the body using an artificial kidney machine called a dialyzer. This is usually done 3 times a week for about 3 to 4 hours each session, typically at a specialized dialysis clinic, although home hemodialysis is also an option for some. To perform HD, you need reliable access to the patient's bloodstream that allows for high blood flow rates. This is usually achieved by surgically creating an arteriovenous AV fistula, preferred method, connecting an artery directly to a vein, usually in the arm, or an AV graft, using a synthetic tube to connect an artery and vein. For temporary use, a central venous catheter might be placed. Before each HD treatment, nurses must carefully assess the vascular access. They listen for a bruit, a whooshing sound heard with a stethoscope, and feel for a thrill, a buzzing vibration felt by palpation. Both indicate good blood flow through the fistula or graft. They also check pulses and capillary refill in the extremity distal to the access. A crucial patient safety rule that everyone needs to know is no blood pressure measurements, FARV insertions, or blood draws should ever be performed in the arm that has the hemodialysis access, fistula, or graft. This is to prevent damage, clotting, or infection of this vital lifeline. Common complications during HD can include hypotension, low blood pressure, muscle cramps, infection at the access site, clotting of the access, and sometimes disequilibrium syndrome, neurological symptoms caused by rapid fluid solute shifts.
And finally, the ultimate replacement therapy, the one that comes closest to restoring normal kidney function: kidney transplant. What does that involve, and what are the major challenges afterwards?
A kidney transplant involves surgically placing a healthy kidney from either a living donor, often a relative, or a deceased donor into a recipient whose own kidneys have failed. Before surgery, extensive testing is done to ensure compatibility between the donor and recipient, especially looking at blood type and HLA, human leukocyte antigen, tissue typing. Patients usually undergo dialysis within 24 hours before the transplant surgery. Postoperatively, the new kidney ideally starts making urine right away, sometimes quite profusely. Urine output is monitored very closely, often hourly for the first 48 hours. The urine might be pink or slightly bloody initially. The biggest long-term challenge after a kidney transplant is the risk of rejection, where the recipient's immune system recognizes the new kidney as foreign and attacks it. To prevent this, patients must take powerful immunosuppressant medications every day for the rest of their lives. There are different types of rejection. Hyperacute rejection happens within minutes to hours, is very severe, and requires immediate removal of the transplanted kidney. Acute rejection is most common in the first few weeks to months, but can occur up to 2 years later, and is often treatable with increased immunosuppression. Chronic rejection occurs gradually over months to years, leading to slow deterioration of kidney function. Other potential complications include infection due to the immunosuppression, blood clots in the vessels of the new kidney, narrowing of the renal artery, and side effects from the immunosuppressant drugs themselves. Despite these challenges, a successful kidney transplant can offer the best quality of life and longevity for patients with ESKD.
So what does this all mean in practical terms? We've talked a lot about conditions, treatments, But behind every diagnosis, every treatment plan, there are crucial numbers, lab values. Let's try to make sense of some of the most important lab values that really tell a story about our health, especially related to the topics we've covered.
Absolutely. Understanding your lab values is empowering. It helps you participate more actively in your care, ask better questions, and truly grasp what's happening inside your body. Let's start with a really common one, the complete blood count, or CBC.
Right, the CBC. It gives us a snapshot of our different blood cells. What should we look for there, connecting back to things like anemia or infection risk?
Okay, so in the CBC, the red blood cells, RBCs, hemoglobin, HEB, and hematocrit, HETT, all tell us about the oxygen-carrying capacity of the blood. Low levels indicate anemia, which can cause fatigue, shortness of breath. High levels might suggest dehydration or a condition called polycythemia. White blood cells, WBCs, are our immune system soldiers. A low count, leukopenia, suggests a weakened immune system, increasing infection risk often seen during chemo. A high count, leukocytosis, usually points to an active infection or inflammation, but can also be seen in leukemia. Platelets are tiny cells essential for blood clotting. Low counts, thrombocytopenia, typically below 150,000, mean a high risk of bleeding or bruising. High counts, thrombocytosis, can increase the risk of abnormal blood clotting. Now, a really critical component, especially in cancer patients undergoing chemotherapy, is the absolute neutrophil count, or ANC. Neutrophils are the main type of WBC that fight bacterial infections. The ANC tells us the actual number of these mature infection-fighting cells available. You calculate it using the total WBC count and the percentage of neutrophils, segments and bands. A normal ANC is generally considered above 1,500 cells per microliter. An ANC less than 1,500 indicates neutropenia, meaning an increased risk of infection. An ANC below 500 is considered severe neutropenia, putting the patient at very high risk for serious infections. This number directly guides decisions about things like starting chemo or implementing strict infection precautions, neutropenia precautions.
That's incredibly specific and really highlights the practical importance of knowing that ANC for infection risk. Now let's move to another common panel, the Comprehensive Metabolic Panel, CMP, which covers electrolytes, kidney function, liver function.
Right, the CMP is a treasure trove of information, especially for kidney health and electrolyte balance. Key electrolytes. Sodium, NETs levels, low sodium hyponatremia, can be seen in conditions like SIADH or fluid overload. High sodium hypernatremia usually signals dehydration. Potassium, K, low potassium, hyperkalemia, can cause muscle weakness and dangerous heart rhythms. High potassium, hyperkalemia, is a major concern in renal failure and can also cause life-threatening arrhythmias. Calcium, HuGA, low calcium, hypocalcemia, can cause muscle cramps or tetany. High calcium, hypercalcemia, is often seen with bone metastases or certain cancers, or hyperparathyroidism. Then you have the kidney function tests. BUN, blood urea nitrogen, and creatinine. These are waste products filtered by the kidneys. High levels generally indicate that the kidneys aren't filtering well, suggesting dehydration or renal failure. The BUN can also be high with high protein intake or GI bleeding. And finally, the GFR, glomerular filtration rate, which we discussed with CKD, it's usually estimated based on creatinine levels, age, sex, and race. It's the most crucial indicator for staging chronic kidney disease. Remember, a GFR below 15 LMN signifies end-stage kidney disease.
And what about urine tests? They can reveal a lot too, right? Especially for kidney and urinary tract issues like UTIs or kidney damage.
Indeed. A simple urinalysis, UA, can provide many clues. Finding positive nitrites or leukocyte esterase strongly suggests a bacterial infection like a UTI. Seeing red blood cells, RBCs, could indicate trauma, stones, infection, inflammation, or even cancer somewhere in the urinary tract. White blood cells, WBCs, point towards infection or inflammation. Significant protein in the urine, proteinuria, is a key sign of kidney damage, seen in CKD or glomerulonephritis. Glucose or ketones might indicate uncontrolled diabetes. Specific gravity tells us about the kidney's ability to concentrate urine. If the UA suggests infection, a urine culture, UC, is often done. This test attempts to grow bacteria from the urine sample. A positive culture, usually defined as growth greater than 100,000 colony-forming units per ml, confirms a significant bacterial infection, bacteriuria, and helps identify the specific bacteria and which antibiotics will be effective against it. You see how these values are all interconnected. They paint a holistic picture of organ function, fluid balance, infection status, and overall disease progression.
Understanding the medications we've mentioned throughout this deep dive is just as vital as knowing the conditions themselves, wouldn't you say? Let's quickly highlight a few key types and their main roles, maybe some important considerations.
Absolutely. Medications are powerful tools, but they also come with potential side effects and interactions. Knowing their purpose and key considerations is crucial for safe and effective treatment, both for patients and caregivers.
Okay, starting with something that often comes up during cancer treatment, dealing with nausea. What's a key player there?
For nausea related to cancer treatments, especially chemotherapy, a very common and effective medication is ondansetron, brand name Zofran. Its primary role is to block serotonin receptors in the brain and the gut that trigger the vomiting reflex. It's often given preventatively before chemo starts. It's generally well tolerated, though a headache or constipation can sometimes occur.
What about medications crucial for managing hematologic conditions like low blood counts or clotting issues?
Right. In hematology, we use antibiotics extensively, both to treat active infections and sometimes prophylactically to prevent infection in severely immunosuppressed patients, like those with very low ANC. Anticoagulants, like heparin, given by injection, and warfarin, oral, are used to prevent or treat blood clots, thrombosis. A key point with warfarin is monitoring the INR, International Normalized Ratio, blood tests regularly to ensure the dose is therapeutic, usually aiming for an INR between 2 and 3 for most indications, making sure the blood isn't too thin, risk of bleeding, or too thick, risk of clotting. Corticosteroids, like prednisone or dexamethasone, are used frequently to reduce inflammation and suppress the immune response in various conditions, including some leukemias or autoimmune blood disorders. We mentioned hydroxyurea specifically for sickle cell disease. Its main role is to increase fetal hemoglobin levels, which helps reduce the frequency of painful vaso-occlusive crises. And NSAIDs, nonsteroidal anti-inflammatory drugs like ibuprofen or naproxen, are great for pain and inflammation. But, as we've stressed, they must be used very cautiously or avoided entirely in patients with significant kidney disease, CKD or AKI, due to their potential to cause or worsen renal toxicity. Opioids remain the mainstay for moderate to severe pain, especially cancer pain or sickle cell crisis pain.
Then we have medications specifically targeting urinary conditions, like incontinence.
Yes, for urinary issues, particularly urge incontinence or overactive bladder, anticholinergics antimuscarinics are commonly prescribed. Examples include oxybutynin or tolturodine. Their main role is to reduce bladder spasms by blocking certain nerve signals, essentially relaxing the bladder muscle, the detrusor, and increasing its capacity. A common side effect patients should be aware of is dry mouth and sometimes constipation or blurred vision.
And finally, a few key considerations for kidney medications.
For patients with kidney disease, medication management requires extra care. Many antibiotics, especially those eliminated by the kidneys, often need their dose adjusted based on the patient's level of renal impairment, their GFR, to prevent accumulation and toxicity. Diuretics, particularly loop diuretics like furosemide, Lasix, are essential tools for removing excess fluid in conditions like CKD, heart failure, and sometimes hypertension, especially when accompanied by fluid overload. They work by making the kidneys excrete more sodium and water. Monitoring electrolytes, especially potassium, is crucial with diuretics. Conversely, potassium chloride supplements are given to replace potassium when levels are low, hypocalcemia. However, it's critically important to remember that potassium supplements are generally contraindicated in patients who already have high potassium levels, hyperkalemia, or severe renal impairment, as giving them more potassium could be extremely dangerous. It really highlights this constant balancing act in medicine, achieving the therapeutic effect of the drug while carefully managing its potential side effects and considering the patient's individual organ function, especially the kidneys. It truly underscores the personalized nature of drug therapy.
Wow, we have truly covered a vast territory today, haven't we? It feels like we've gone from the microscopic world of, cancer cells and viruses, all the way to the systemic impacts on our blood and kidneys, and then looking at the really complex interventions that save lives and improve health outcomes. This deep dive was designed really to empower you, the listener, to transform that feeling of maybe information overload into clear, actionable knowledge. Hopefully, you're now better equipped to recognize signals, understand prevention strategies, ask informed questions, and just engage more meaningfully with your own health journey or that of a loved one.
Indeed, we've explored those crucial early warning signs of cancer, delved into proactive prevention strategies, diet, lifestyle, vaccines. We unpack the complex mechanisms of metastasis, how cancer spreads. We clarify the roles of oncoviruses. We navigated the complexities of cancer staging using the T&M system and discussed major treatment modalities like radiation and chemotherapy, including managing their side effects. And importantly, we covered those critical oncologic emergencies that demand such rapid response. And then beyond cancer, we journeyed through the intricacies of blood disorders, sickle cell disease, leukemia, anemia, transfusion reactions, really understanding how vital our hematologic system is. We then shifted focus to the incredible filtering prowess of our kidneys. We addressed urinary incontinence, common infections like UTIs, the agony of kidney stones, and really clarified the profound differences between acute kidney injury and chronic kidney disease, culminating in our discussion of kidney replacement therapies like dialysis and transplantation.
It's definitely a lot to take in, but I think the core message that comes through is powerful. Proactive health is powerful. Knowing the warning signs, actively engaging in prevention, understanding screening recommendations, recognizing emergencies when they happen, these aren't just abstract medical facts. They are tools. Tools for self-advocacy, tools for making informed decisions, and ultimately, tools for achieving better health outcomes. You're now better equipped to ask those informed questions and engage meaningfully with your own health journey.
Considering all we've unpacked today, the science of prevention, the power of early detection, the body's incredible resilience, but also its vulnerabilities, here's a final thought for you to take away. What single proactive step, based on something you heard today, will you prioritize differently in your own life to truly invest in your long-term health, starting now?
Thank you so much for joining us on this deep dive into these vital health insights. We sincerely hope you feel more informed, perhaps more confident, and definitely more prepared for whatever your health journey may bring. We'll see you next time on the deep dive.